Thank you very much, Mohammed, and organizing committee. Okay, so we'll start. So stroke is a major health burden. It is still the second leading cause of death worldwide and leading cause of disability among adults. So the global burden of stroke, you can see in this slide, our area fits around 200 to 300 per 100,000. That's the incidence. What about the local data? There has been an old study in 1995 by Dr. Adil Jishi. It was estimated to be 57 per 100,000. A more recent trial that I participated in, it was published in International Journal of Stroke 2015 by Munal Benna et al. It has doubled, so it has reached 110 per 100,000. And it's estimated to be on the rise as well. So how do you identify stroke? By FAST or BFAST, so balance problems. Has the patient lost vision in one or both eyes? Any facial droop? Is there arm weakness? Any speech problems? And of course, you have to act timely. So these are the emergency stroke care. Depends on 4-step chain survival. So first of all, general public has to be there, recognize the stroke symptoms, react appropriately, emergency call, then emergency medical services with prompt evaluation, pre-notification of the healthcare providers, and then transfer to the stroke unit. This is the NIH assessment. This is 11 points scale. So it gives basically tells everyone how severe the stroke is. So between 0 to 42. So less than 0, less than 5, usually minor stroke, 5 to 15, moderate, 15 to 20, moderate to severe, and 21 to 42 is severe stroke. Another thing is commonly used is the aspect score. This is radiological. Aspect score is the Alberta Stroke Program Early CT score. It's a 10-point quantitative score, and then each area that is affected, we subtract 1. So there are 2 levels. At the level of the basal ganglia, you can see here, head of caudate, insula, internal capsule, lentiform nucleus, and then the cortical regions, M1, 2, and 3. And 1 level above that, you can see M4, 5, and 6. So the aspect score is demonstrated in patients of more than 7, they're usually more likely to benefit from therapies, whereas those less than 5, it means that they have severe stroke, are less likely to benefit from treatments, and more likely to have complications like bleeding. Okay, so the goals of acute stroke imaging, you have the 4 Ps. First P is the parenchyma, so assess early signs of acute stroke and rule out hemorrhage. The pipes, where we assess extracranial circulation, carotids and vertebral arteries of the neck, as well as the intracranial circulation for evidence of intracranial thrombus. Perfusion to assess the cerebral blood flow, blood volume. I'll talk about that in a minute. And then the penumbra. It's very important, the penumbra or the salvageable tissue. I'll talk about this in some details. So this, you can see this on the plain CT, hyperdense sign on the left, and then you can see on the right hand the absent flow and the middle cerebral. Here again, you can see absent flow. This is a 3D representation. You can see absent MCA here. Okay, so about CT perfusion terminology, there is cerebral blood flow, which is the flow rate or volume of blood through cerebral vasculature in mLs per 100 grams per minute. Then cerebral blood volume, that's the volume of blood, and the mean transit time. This is important to recognize, to explain the penumbra. So I'll just explain here. So this is the normal cerebral blood flow above this line here, usually normally above 55, so 55 to 110. Where we have normal blood flow, and below 10 is the infarcted area. So many residents or students ask me why it's so urgent to take actions immediately. So you're trying basically to save the area in between, the penumbra here, between 10 and 20 or up above that. Okay, so CT perfusion, you have the CBV used to identify the core of the infarcted tissue, and then reduce cerebral blood flow or increase mean transit time to identify the penumbra, or potentially salvageable tissue. Here you can see in the dark area, the necrotic area or infarcted area. Here the reduced cerebral blood flow, you can see or increased mean transit time for the penumbra. So every second counts. So every minute, actually, you're losing about 2 million neurons. So you have the infarcted area in red, and then the penumbra in green. So why it's so important? So you have to act really fast so that this dead area or infarcted area will not expand, and you can save the area around it, right? It so you either do it by CT perfusion or MRI if you have the facility, MRI perfusion. So diffusion weighted and perfusion or flare mismatch, or by the CT perfusion diffusion mismatch. So this is just another representation. You can see cerebral blood volume, flow, mean transit time. This is if you have MRI mismatch. If you have the facility, such as in King Hamad Hospital, they have this in the ER. So you have the DWI. You can see you have an area. This is a mismatch. You have a lesion on the DWI with a normal flare. So this is what you want to save the area. Here you can see they're matched. So they're not good candidates for therapy. This is just the rapid software. So this is, you have MR or CT, and then the computer will process it and will produce some images, so it becomes easy to recognize the penumbra and the ischemic core. So this is what you want to see. There is a mismatch. You can see in purple. So this is the ischemic core, and this is the green area is the penumbra, the area that you can salvage. And this is what you don't want to see. It is matched, so there's not much area to save. We spoke about this already. So basically the 4 steps. So exclude bleeding, confirm the diagnosis, severity of stroke, and then you roll out contraindication. Then of course you give the treatment. And the TPA IV has shown it's very useful to increase between 30 to 50% improvement in across all functional outcomes. So this is what we tell the patients in the ER, about 35% improvement versus 3 to 5 risk of bleeding. And you can see this is the evidence. It's also a very time-bound treatment. So it is more useful in less than 3 hours, then less so between 3 to 4.5, and then more than 4.5. And you can see it does not matter the severity of stroke in the NIH assessment score or the age. Below 80 or even above 80, there has been some benefit, very clear benefit. You can see here again, we're demonstrating the time. You can see it's more useful when it's given early, within 1 and 1.5 hours, versus 1.5 to 3, and then beyond that, 3 to 4.5. Again, here the numbers needed to treat. Less than 90 minutes. It's as much as number needed to treat means how many will benefit. It's 4 to 5. Between 90 minutes and 3 hours, it goes up to 9. And then 3 to 4.5, it goes up to 14. So the sooner, the better. This is the Sedan score. It just can help you predict who will have hemorrhage, with sugar level, early infarct on the CT, dense or hyperdense sign, their age, and NIH assessment score below 10 or above 10. Of course, the higher, the more likelihood they will have hemorrhage. This is recanalization and after 1 hour with IV TPA. You can see it's variable. If it's more proximal, like an ICA or proximal MCA, it is, of course, between 8 goes up to 24 versus when it's in the branch up to 40 or 50%. So IV has limitation, IV TPA has limitations. So like we said, ICA and M1 occlusion have lower rate of recanalization than M2 or M4, as well as the clot size. So the clot size, the magic number here is 8 millimeters. So if it's more than 8 millimeters, it's very unlikely that it will recover with IV therapy alone, and they need mechanical thrombectomy. Again, it's shown in this slide. These are the large vessels, just to demonstrate. You have MCA, M1, M2, ACA, ICA, basilar, and the PCA. Okay, we're doing with time, okay. So this is just an overview of how things developed from the intervention point of view. So as early as 1999, they tried, this is about maybe 5 or 10 years after using IV TPA, they tried injecting it intraarterially. Okay, but that didn't work so well. Then ultrasound in 2003 on the top of the catheter tip, okay. And then they developed some coil retrievers. This you can see it like a corkscrew or like a net. In 2009, the Penumbra, which is like an aspiration. But the real breakthrough came in later than that, around 2013 and 14, with stent retrievers. Okay, so then proven by trials that I'll mention in a minute. So this is the earlier devices, the MERCI catheter. You can see it's like a corkscrew. It didn't work so well. It was sort of pushing it into the clot. It didn't work so well. And actually, the initial trials were negative. This is the Penumbra catheter. It works by suctioning the clot. This is the good one, the Solitaire Stent retriever. I'll show you in the slides how it works. So this is actually what they're using currently, okay, up to now. So mechanical thrombectomy. So the wire and catheter is passed from the femoral artery over the aortic arch through the internal carotid artery to the middle cerebral artery and through the clot. You can see in the diagram. Then the guide catheter is removed and the stent catheter advanced over the wire through the clot. Then the catheter is pulled back and stent is deployed. So it opens up into the clot. And then the stent embedded in the clot traps the clot within the mesh. So it is there. And then the whole thing is pulled out. So the stent with the embedded clot is pulled back into the guide catheter and the entire system removed from the femoral artery. You can see that's the mesh, and this is the trapped clot over there. So this is what it looks like. Okay, so this is the evidence for mechanical thrombectomy. It came from 5 major trials published in the New England Journal of Medicine in 2015. The first one, Mr. Clean, Escape, Extend IA, Swift Prime, and Revascat. You can see the Tiki 2B3A. This is complete recanalization. You can see difference between 60 to 80%, around 80%. And this is the restoration of a modified Rankin score. So below 3 is totally independent at 90 days. You can see different 30%, 50, around 70%, so all of that. And this is the death rate. So you can see this versus the standard therapy. Okay, so these are the negative trials. So before 2013, like I said, the earlier devices were not as advanced as the stent retrievers. It was negative, these trials. Then in 2015, you can see on the right of the line here of difference, you can see they are all positive studies, these major 5 trials. Okay, so who do we know benefits? All right, so the criteria should be more than 18, the age of more than 18, functionally independent, like I mentioned, modified Rankin score below 2. Significant neurologic deficit, so it has to be NIH score more than 6. The onset to groin puncture should be less than 6 hours. Radiological criteria, no intracranial hemorrhage, no large established stroke. That's less than 1/3 of the MCA territory. Okay. And anterior circulation, large vessel occlusion. All right. What about late presenters? This is very important because majority of acute ischemic stroke present beyond the traditional window. All right. So about 1/3 of them are unwitnessed or wake-up strokes. Dawn and Diffuse 3 attempted to answer these questions. The goal is to treat these slow progressors, so they still have salvageable tissues. All right, so the Dawn trial attempted thrombectomy between 6 and 24 hours after stroke with a mismatch between deficits and infarct. For the sake of time, we'll go a bit quick. Okay, so they used mismatch, clinical and radiological mismatch. So they used like the same criteria, age more than 18, baseline NHS score more than 10, infarct core volume, last well known between 6 to 24 hours, and modified Rankin 0 to 1. They used mismatch between on the MR or CT perfusion, so between 0 to 20 cc infarct plus NIH score more than or equal 10, and those above 80, and those below 80, 30 mLs, and NIH score more than 10. So the outcome, there was a difference, functional independence, about 36% absolute difference between the 2 groups, so in favor of the intervention. The Fuse 3 trial attempted thrombectomy for stroke at 6 to 16 hours by selection by perfusion imaging. So they used similar clinical, but imaging, they dependent on the infarct size less than 70 ml by CT perfusion or rapid. MR diffusion ratio, volume of ischemic to infarct of 1.8 or more. And again, it showed significant difference, the more favorable modified Rankin score at 90 days, 45% versus 17% in the standard therapy. Okay, so endovascular criteria with proven benefit. So it has to be those who are above NIHSS score more than 6, time less than 6 hours, from last seen well to groin puncture, age more than 18, premorbid condition, modified Rankin score should be less than 2. They should be independent. And life expectancy should be more than 12. Radiological, they should have no intracranial hemorrhage and a small ischemic core. For endovascular criteria, between 6 to 24 hours, they all must meet the criteria NIH score of more than 10 by the Dawn criteria, NIH assessment score more than 6 by diffuse trial. So between 6 to 24 hours by Dawn and 6 to up to 16 hours by diffuse criteria. Age more than 18 years, premorbid condition, they should be modified Rankin score less than 1. And life expectancy more than 6 months. Radiologically, they all must meet the criteria with no intracranial hemorrhage, intracranial ICA or MCA M1 occlusion by CTA or MRA, with a small core volume, again on CT, diffusion-weighted MRI or CT perfusion. Those who were no endovascular treatment offered clinically, if they had NIH assessment score less than 4, time more than 24 hours of last known well, premorbid condition, if it was modified Rankin score more than 3, so their premorbid condition is not good, life expectancy of less than 12 months, and then they did not meet the criteria by Dawn criteria, that is 6 to 24 hours, or by diffuse, so 6 to 16 hours from last seen well. Radiologically, if meets any, with the intracranial hemorrhage, of course, would preclude using these interventions, and no proximal large vessel occlusion. So just to conclude, I have 2 minutes. So this is just a diagram to make it easier. How do you manage these patients? So patients with suspected stroke, if they fit here like less than 4.5 hours, CT angio, large vessel occlusion absent, they go with IV thrombolysis. If they have large vessel occlusion, they go with IV thrombolysis and mechanical thrombectomy. If it's more than 4.5 hours, you go with CT angio and CT perfusion of more than 6 hours. Large vessel occlusion and threshold core perfusion mismatch, if 6 to 24 hours, they can undergo mechanical thrombectomy. If they don't have large vessel occlusion, then you do MRI with diffusion flare mismatch. If they have salvageable area, then you can go with IV thrombolysis. Okay, thank you.